communication and relationship.
Well, the last point in this part, which is indeed is very dark rising in Iraq, it is the risk assessment for suicide thoughts or suicide attempts. The problem, personally, I had 3 patients. They tried to commit suicide. Alhamdulillah, they didn't die. Like, they tried indeed, and we tried them. Yeah, but for the physicians, maybe it is very difficult. They connect with patients. They feel that there's something wrong, but they don't know how to deal with it.
Yeah.
So,
I think, particularly for people who have a stronger affiliation with faith, and in communities and societies where faith is a stronger element, there can be an added experience of shame for having a suicidal thought. Now, do people have suicidal thoughts intentionally? Do they want to identify ways of killing themselves? Or is it something that emerges? Now, there are different models and different theories for this, but one of the prevailing models is that as a symptom of depression, as a symptom of the hopelessness, one of the things the mind does is try to find a way out. Yeah, and that open thinking is going to include, well, one way out of this is to not be alive. And some people may have intrusive thoughts, unprovoked, unintentional, just thoughts that come into their mind about being better off dead. Yeah. So we can't always say that this is something that the person is intentionally thinking about. Now, they may move from that depending on the level of distress, the level of desperation, the level of hopelessness, increasingly to having more intentional thoughts, identifying a plan, and executing a plan, preparing for it. So in terms of the assessment that a physician can undertake, there are a number of things to look out for, and a number of ways in which we can use this knowledge of the process. So first of all, does the person have any thoughts about harming themselves or killing themselves? And if there's an element of shame around this, then the person will just say no. It's easy to just say, no, I'm not having any of these thoughts. So rather than just asking if they've had any of these thoughts, in a quick risk assessment, starting off by saying, when people are in really difficult circumstances, sometimes it's normal for them to have these thoughts. Have you had anything like this? So you're almost giving them permission to be honest. Yeah. Normalizing that this can be something people experience, then asking them, rather than just asking them straight away. So you've prepared them to give you a more honest response. Of course, there is no guarantee, but this increases the possibility of them giving you an honest account. And then if they're able to say, yeah, this is something I've experienced, again, not moving too quickly with a technical assessment, bringing in some of the humanity and saying, that must be really hard. You must be in a really difficult position. Things must feel really hard for you to be having those sorts of thoughts. And maybe actually having some of these thoughts in your situation is understandable and normal. We're not saying it's justifiable. We're not agreeing that you should kill yourself. We're just saying that, you're not on your own in this. This happens. And because we know it does happen, we also know that we can support you. There can be a way out of it. This doesn't have to be it. Important to take a history. The biggest predictor of future risk is past risk. Have they ever attempted to harm themselves? Have they ever attempted to take their life before? And if they're having these thoughts, there's still a big distinction between passive and active suicidal ideation. So sometimes people can just have thoughts about not wanting to be here. Sometimes people can have more specific thoughts about, I am not going to be here. I'm not going to continue like this. Of course, there can be spontaneous suicidal ideation and action, but I guess I'm talking about what we might do in a more regular assessment. If you identify that there is something more active about the thought, being able to talk about plans. Now, some clinicians will almost avoid being too specific in doing a risk assessment on suicidal ideation because of their fear that if we talk about it, I don't want to give them some new ideas and then they act on it. All the research shows that doing a risk assessment never increases the risk of someone acting on their suicidal ideation. Yeah, so that's a myth that I just want to bust here. So asking them what plans they have. Now, they may have a vision of jumping off a bridge, or just suffocating themselves, hanging themselves, taking an overdose of medication, walking in front of a lorry or a train or something. But then we want to follow that up with identifying the intent. So how strong is your intent to act on this plan? Because the plan may just be there, a plan that you don't ever intend to act on, but we want to ask, how far have you taken it? Do you have a weak intent, a medium intent, a strong intent? Or you could rate it on a 0 to 10 scale, or some way of measuring the power of their intention. And whether they've taken any steps. Have you started to gather some medication that you might take an overdose? Have you thought about which bridge and what time you would go? Have you started writing a letter maybe to your family? Have you started, making arrangements, preparing your will, or saying, I need to pay off my debts so that I can leave this world with no issue? So just checking and having an open conversation about that. And then I guess once we've assessed some of that, then we need to do some sort of management. And I think, that's probably a more detailed discussion, but I think just to highlight some of the key points that might be important in managing the risk is, well, as the doctor, I can't be here with you all the time. If you start feeling this way, then who can you speak to? And what we often find in a person's suicidal risk profile is that it's not at a high level risk all the time, that it'll fluctuate. When they're feeling really distressed and hopeless, it'll peak. And it's that peak which is the most dangerous phase. So if during that peak they're able to speak to someone, and this is why helplines often here in the UK are so effective, is because just for the worst part of the risk, they're speaking to someone, which helps them get through it. Because once they've gone over the peak, then they're coming back into a safer territory. Then when they're approaching the peak again, we just want them to be able to have someone to talk to. And sometimes when they're not feeling so desperate is the best time to get them to tell maybe their mother, maybe their husband, maybe their child, you know what, like I've been having these thoughts, and inshallah, I don't want to act on these thoughts, but I don't feel safe. So when I'm having these thoughts, I'd like to speak to you. It's a really hard thing to do, but having that conversation can literally save someone's life. Mm-hmm. So knowing who to speak to and speaking to them in advance, and just exploring with them what else, when you notice that things are going in that direction, when you're going up that risk curve, things are starting to feel more desperate, what can you do to disengage yourself from that? What will bring you hope? What steps can you take to start countering that? And there's a whole range of things that you can explore with them.
Yeah. One of the things I realized, maybe your explanation about it, that from the statistics, we don't see a gender difference between those who commit suicide, men and women, but those who come to talk more are women. So first, I thought that women have this thought more, but I realized maybe that women are more able to talk about it, while men don't. They close up on this. They don't talk about it.
Yeah, no. I think it's a phenomenon that's seen globally, that women do find it easier or more able to discuss what the distress is, and men can experience a higher degree of shame and reluctance in being able to talk about it. There's also something about men expressing their distress in different ways. Men are more likely, not always, but more likely to express their distress through anger. because it may be a more socially acceptable way of them expressing their emotion compared to women. But I think, what can we do to change this, I think is important. And I think it can start on a day-to-day basis in our everyday conversations with each other, to make it more acceptable for us to experience distress. And that distress isn't a sign of weakness. It's actually a normal emotion in response to the circumstances that we're in. And I guess, again, looking at a faith-based perspective, we have plenty of examples from religion that show that those that we revere, the Aima, the prophets, the imams, expressed emotion all the time. If we're supposed to be created as perfect beings, as the best of creation, we were created with tear ducts. Why? There must be a reason. There must be a wisdom. We were created with a heart. We were created with that amygdala, as part of our emotional expression. So emotions are there to be expressed. And the expression of emotion actually may be a sign of strength rather than weakness. But this societal conception and judgment of that is going to take time to change.
Yeah. So I think that my colleagues, they don't have any questions, maybe because you speak English fast for them, so they prefer to watch the record later. And I will jump for the third part, which is the last part, about how to cope with the stress as a physician. The situation within the pandemic.